Hello friends, this is Dr. Jaitly, your cardiologist on your favorite source of learning about human heart and cardiology. Welcome again on MuniMeterHealth, your favorite source of learning cardiology and human heart health. I'm Dr. Jaitly from New York, your cardiologist. I'll be talking very briefly, just like I always do in one short video here. The subject today is what is contrast-induced acute kidney injury, as referred to in future as AKI. Okay, interestingly enough, I've drawn some schematics here on the right side of the panel, if you will. Here's the heart showing the coronary circulation outside, okay? You have the kidneys, the two set of kidneys. The right kidney is slightly lower because the liver is involved here and liver is right in this situation. So, anatomically, the right kidney is slightly lower than the left. You have the descending aorta, and of course dividing into the two iliac vessels and later on dividing into the femoral vessels. So the reason I've shown you here is because the angiographers love to use the femoral approach, and many angiographers are now starting to use the trans-radial approach, if you will. Okay, and then trans-radial approach is becoming more popular for some very important reasons, which I'll be discussing that in a second now. So the relevance is very clear with these schematics, so this way we can follow the points here now. Now, acute kidney injury has become almost another unfortunate complication as a result of the contrast that is being employed. Even though we have made tremendous progress in how to analyze what limit, the content of the contrast, be the molecules and the ions, for instance, within the contrast, and not only that, even the pH and so many other things that have been discussed. Again, that's beyond the scope of the video here. My concern is let us understand what are the possible clinical takeaway messages here out of the contrast that one employs, the best contrast that employs in the cath lab for angiography. Now, hypotension, for instance. Now, if a blood pressure drops for, say, more than 20 to 30 minutes and stays low, when we say low, we're talking about systolic blood pressure less than 80 millimeters, because that's almost like, it's almost life-threatening, you would say. Patient is a shock. Now, remember, the beauty about the kidneys are that it can sustain even normally a partial oxygen pressure of 10 millimeters of mercury. So remember that the partial pressures, even in a totally functional normal kidney, in the presence of normal blood pressure, they can even survive when the oxygen content is only 10 millimeters. Remember, the partial oxygen pressures are an indicator, are an index or a criteria or marker to suggest how low can the organ survive. Now, for instance, the brain cannot even survive for less than 5 minutes. More than 5 minutes, it'll be, it's called brain death if the pressures drop that low. That's why certain organs, you have to really revive these low pressures rather quickly. Heart, for instance, heart can take it for a few hours, whereas the kidneys cannot even sustain a low blood pressure also for that long. So remember that. So these are some of your criteria that one has to remember that. So in other words, a stress beyond 30 minutes of a systolic pressure more than 80 millimeters, a systolic pressure less than 80 millimeters can result into an irreversible acute kidney injury. We call it AKI. Now, volume of the contrast really matters. Why? It matters because if you were to use, say, in a normal, let's put it this way, in a normal angiography, one employs about 80 ml of the contrast. If you were to do a PCI, you would employ about 150 ml. Okay, and the highest amount that is being utilized right now is with the TAVR. The TAVR procedure I've talked about in another video, where you do a transcutaneous aortic valve replacement that requires multiple boluses. Remember, it's a great procedure where cardiac surgery, open heart surgery can be avoided, and you can replace a valve. But the problems are, you have to pay attention to the boluses that are being administered, especially with the contrast. So multiple boluses are being employed. So the higher the amount, the worse is the acute kidney injury. Contrast tends to linger in chronic renal failure patients. If the kidney is already damaged here, for instance, one sees that this is the contrast will tend to linger. What do I mean by saying? I mean by saying this is that if you were to do an MRI or a CAT scan, say 6 months later, the contrast might show up still in these kidneys here as a result. And so just be mindful that the contrast tends to linger longer in renal failure patients, and that speaks of the acute kidney injury in these patients. Trans-radial approach. Now, this is a very, very important thing that has come up recently that we have realized. Now, remember, all angiographers, primarily, at least from my school, I'm from the older school, they were all angiographers were trained to use the femoral approach. So we had the femoral artery as an axis to offer, and the catheter used to pass up into the iliac vessels, up into the descending aorta, and then drop into the arch of the aorta, and then finally here you would engage in one of the coronaries and a coronary ostia, and then start injecting the contrast. So that was the femoral approach, so transfemoral approach. We call it the TFA. Now TRA, which is the transradial approach, it bypasses all this descending aorta. It bypasses pretty much the arch of the aorta. So what happens is it straight drops in through these great vessels which are arising from here, and these vessels, say it will drop in from the brachiocephalic in the right side, or maybe the left subclavian on the left subclavian artery from the left side, and you could actually bypass the entire aortic injury. So the post-op complications or intra-cath complications are minimized with transradial approach, and therefore the contrast also used is much less. Here the contrast is higher. Now, good old school thought about the mucomist doesn't work as good at all. In fact, it's been shown by randomized trials, double-blinded randomized trials, that mucomist is given to patients prior to the cardiac catheterization or use of contrast. Those patients did as good as the patients who did not receive the mucomist. Again, it's a benign substance, but the fact is it's useless. So don't even bother with mucomist anymore. It doesn't lessen the acute kidney injury in any individual. So if that was on the boards, don't even worry about mucomist. Okay, but of course, practically in clinical states, one should really not even bother using it. Now, IV boluses, this has become very important. IV bolus of a saline, if normal saline you were to use 250 to 500 ml, in the 20 minutes. Remember, in the 20 minutes prior to, let's get this off. 20 minutes prior to the IV say angiography, when you're doing the angiography, coronary angiography, it is turning out to be one of the greatest protectors for the kidney injury, against the kidney injury. So saline use, a bolus of 250 to 500 ml is turning out to be the greatest asset to prevent acute kidney injury, or AKI. So very important. Again, it doesn't have to be given overnight or over a period of 6 hours and like keeping a KVO or giving it 10 or 20 cc an hour. No, that doesn't play out well. It is the 250 to 500 ml of bolus. Again, I insist, bolus, and that may be on the boards for you guys, especially the fellows who are taking the cardiovascular boards. Mortality at 30 days is, it has been suggested as 3%. Whereas at 12 months, it is almost 23% from acute kidney injury. So if the acute kidney injury has occurred, mortality could be very, very astronomically high. So should not be taken lightly. In other words, after a year, you could have numbers which could be very, very devastating. Only about a quarter of the patients could have very significant problems unless these patients are recognized. They are placed on hemodialysis, etc., and or even become candidates for renal transplants at some point of time. And lastly, but not the least, I do want to tell you that in UK there has been a program where they've tried the hemodialysis, and it's called the Home First, where they overnight dialyze the patient, and they found that is turning out to be a better way to prevent the acute kidney injury in these patients, especially patients who are going for cardiac angiography. Wherever you have these patients who are going for various procedures, contrast use procedures, they found that the hemodialysis and in general the contrast or no contrast, an acute kidney injury can be prevented in these patients if they were to use hemodialysis overnight. So okay, but in any case, we have talked about a few points. Hypotension, volume matters, as I said. The contrast lingers for a longer time in renal failure patients. Transradial approach is better than the transfemoral approach. Mucomist, as I said, is useless. Randomized trials have not shown any benefits one way or the other. saline IV boluses of 250 ml. Remember, it's a bolus which is given rather acutely, and that should be done within less than 20 minutes of the actual cardiac cath, and that could be done in the cath or while the patient is being wheeled into the cath lab. You could do that. Mortality rates are much different at 30 days as opposed to a year. 30 days, it's about 3%, and the year later is almost 23%. So that's really, really accelerated mortality here. And as I said, the trans-radial approach is now becoming very, very prominent. So once again, I thank you for your attention. Thank you for watching MuniMeterHealth, your source of learning cardiology. And again, stay tuned for more such short, interesting videos coming down the line. We try to keep the state-of-the-art cardiology on board for you guys, especially people who are taking the exams and tests. Remember, this is not a channel to offer any medical advice. All we do is educational information, mainly for doctors community as well as for the patient community. Thank you again for watching. This is Dr. Jaitly. So long.